Well, to start out with a definition for co-occurring disorders, in its broadest sense, co-occurring disorders just means two different disorders that a person has at the same time. So a general example might be someone who has diabetes as a physical condition and depression as a mental health condition co-occurring, happening at the same time. For the purposes of this program, there's a more specific definition. Co-occurring disorders is intended to mean somebody who has both a mental health disorder and a substance use disorder at the same time. The folks who have worked with co-occurring disordered populations, one of the national leaders in that area is Dr. Kenneth Minkoff. And he's put together an approach to treatment that we are in the process of adopting in Washtenaw County. And I'd like to spend a couple of minutes talking about the framework that he's kind of lent to the discussion that will help make sense of co-occurring for the folks who are watching. Even among professionals, when there's discussions about co-occurring disorders, there can be confusion at times. You know, is a person with mild depression and who binge drinks on the weekend the same as somebody with chronic schizophrenia who's addicted to crack cocaine? And clearly, you know, the answer is no, those aren't the same sort of disorder. So this framework was come up with to kind of help make sense of discussions around co-occurring disorders. As you can see from the poster board here, it's divided up into 4 quadrants, 4 sections. Section 1 would be understood to be someone who has a mild mental health disorder and a mild substance use disorder. Moving up to, or quadrant 2 is understood to be somebody with a high, you know, intensity psychiatric problem, but a low substance use disorder. Quadrant 3, someone with a low psychiatric disorder, but a high substance disorder. And then quadrant 4, someone who has a high intensity mental health problem as well as a high intensity substance use or addiction problem. To help kind of flesh out what that can look like, I just like to give a brief example of what a consumer who comes into treatment might look like who fits each of these quadrants. In quadrant 1, you know, somebody with a mild depression or dysthymia, sometimes it's referred to, who, like I already referred to, binge drinks on the weekends, might be a good example of a quadrant 1 type of consumer. On quadrant 2, that might be somebody who has a moderate to severe bipolar disorder on the mental health side of things, who uses, you know, snorts cocaine recreationally at parties, let's say. An example of a quadrant 3 person might be somebody with a, say, an antisocial personality disorder who is addicted to crack cocaine. And then quadrant 4, an example would be somebody who has severe chronic paranoid schizophrenia who may also be addicted to marijuana. So those are just kind of a practical example of each of those quadrants. Now the Minkoff model to providing integrated treatment holds to some really core principles or concepts that I'm going to kind of run through over these next couple of minutes. One is that it uses this model to help indicate what type of treatment somebody needs and then to match appropriate effective treatment to where each person is at on a person-by-person basis. Good integrated care, Dr. Minkoff has been to Washtenaw County several times to provide training. One of the things he says every time that he comes is that that duly diagnosed individuals should be an expectation rather than an exception. And what he means by that reflects a lot of statistics that have come about through research studies that show, for example, that if somebody has a serious mental illness, the chances of them having a substance use disorder is greater than 50%. Depending on the type of mental illness and depending on the type of substance involvement, somebody with a mental illness can be from 2 to 9 times more likely to develop an addiction than somebody in the general population. So when somebody shows up at either a mental health treatment facility or a substance abuse treatment facility, it should be an expectation that the staff who are evaluating that person's treatment needs should look for and ask questions about the other type of disorder, so that somebody can properly identify what they're up against and be plugged into effective treatment. Another principle of good integrated care is that effective treatment seems to occur where the treatment staff themselves are empathic, they're compassionate, they meet the person where they're at, they're warm, they're welcoming. Their treatment is continuous. What's meant by that is it takes place with the same provider, ideally, over a period of time. National research has shown that folks with quadrant 4 combination of dual disorders can take up to 2 years of continuous treatment before they really get a grip on some good quality recovery. So a continuous relationship with the treatment staff is important, and also that it needs to be hopeful. Treatment staff need to be able to put a vision of recovery out there in a way that somebody who's up against that double challenge of dual disorders can really grab onto and be motivated by in order to do the very hard work that's involved in appropriating dual recovery. Another element of good, effective dual treatment is to not worry about the question about which came first, the chicken or the egg. And a lot of discussion and debate has occurred over a period of decades now about, did the substance abuse disorder cause the mental health disorder? Did the mental health disorder set somebody up to develop an addiction? And the model of good integrated care takes the position that it doesn't matter which came first. Good integrated care addresses both disorders. It treats them both as primary. It provides treatment to both in an integrated and coordinated fashion. Another important aspect of dual treatment that's integrated is that it really needs to recognize that both are diseases in their own right. And there is such a thing as recovery from mental illness, and there's such a thing as recovery from substance use disorders. And that a blended recovery or a dual recovery is in fact attainable. It's not just a matter of maintaining somebody who with a mental illness on medications for the rest of their life in any greater way than it is with somebody with an addiction that's, you need to just live with your addiction the rest of your life. And what we're finding as efforts are made to integrate treatment is that the mental health treatment world is learning things from the substance abuse treatment world and vice versa. The concept of recovery has been around for a long time in the substance abuse treatment world and in the recovering community. And the mental health community, I think, is able to take on that concept and that perspective and really provide folks with a better vision of hope for what they can achieve, with regard to stabilizing their mental illness and living a higher quality of life. Good integrated treatment also respects where somebody is at in their particular change process. And this is another, relatively recent concept. It's understood that somebody who's perhaps hasn't hit bottom yet or hasn't reached a point of action for their own recovery, they may be ambivalent where they're at. They may be, with their substance abuse disorder, they may be at an action stage of change, but with regard to their mental illness, they may still not want to believe that they have a mental illness. And good integrated treatment takes those stages of change into account, and it does very specific and individualized treatment matching so that we recognize where somebody's at, and you seek to use treatment interventions that meet them where they're at for both sets of disorders.